Hello and welcome to Season 2, Episode 80 of the Physician Assistant Exam Review Podcast. This week, we're going to be continuing with hematology, but specifically covering coagulation disorders and the coagulation cascade. My name is Brian Wallace. I'm the host and creator here at Physician Assistant Exam Review. You can find all of the notes and past episodes on www.physicianassistantexamreview.com. This week is going to be a little bit different. I started spending some time putting together this week's episode, and it's on the coagulation cascade. And what we were going to do, what my plan was to start with, like we always do, the disease processes and treatments and all of that, standard medical stuff when we cover these topics. And honestly, it took me a very long time to put together what was supposed to be the introduction to this section. And it turned into what's going to be all of today's show, because I think it's important to lay the groundwork. And I think it's important to get that overarching view like we talked about. And I'll talk about that a little bit more towards the end. But I think that having a basic understanding, and I know that you took classes that gave you this basic understanding, right? I know that you're in a master's level program that has this background available for you, but a lot of times we study it and then forget it. We learn the details and then move on. So I just want to do this review up front here, and then in the next episode, we will move on to actual coagulation factor disorders, and then we'll do hypercoagulable states in the show after that. That's sort of the setup for this plan. And then I think we're getting close to finish with hematology. So anyway, let's go ahead and get started with some priming questions for today, and you'll start to understand exactly what I'm shooting for here today. How does warfarin thin the blood? How does warfarin work? What is one thing von Willebrand's factor does to increase clotting? What is one thing von Willebrand's factor does to increase clotting or promote clotting? Factor 1A is the tough, stringy endpoint of the clotting cascade. What is its other name? What is its other name? All right, so today we move from leukemia and lymphoma into clotting issues. So hematology has, although it's a very small section of your PANCE, of your medical content, it's got some of the more complicated things to understand and remember. So, like I said, lymphoma and leukemias have always been an issue for me. This section is a little bit more clear, or has been historically a little more clear for me. It has become much more clear in my clinical practice, but understanding it to the level you need to, understanding it in incredible detail, understanding it for what you need in practice, they're all different layers here. And I don't know if anything is better to illustrate this point than the coagulation cascade and coagulopathies and how all of this works. Because in some sense, you need to know the very basics here, of course, and some of you will need to know very, very specifics here. The majority of you won't need a lot of information. It just depends on what you wind up practicing in and how that goes. As far as your PANCE goes, like we've talked about before, what is it, 4 or 5% of your exam is hematology, so it's not a ton. So I think spending a ton of time on detail here is a mistake. I think memorizing the entire clotting cascade and knowing exactly how each enzyme works to activate the next factor is a mistake. I just think that's too much time. I think that's too much depth for the value you're going to get from it. So you'll see as we move through what I believe makes the most sense moving into your PANCE. So today we're going to be covering blood clotting and coagulation. And some of this is I think a lot of this is hard to get your head around until you see it in clinical practice. So blood clots are sort of the process of turning blood from a liquid into sort of like a gelatin. And one of the, one of the best places to see this is on your surgical rotation. Or in your OB rotation when you're doing C-sections. Because what you'll see when you're doing surgery and you have a fair amount of bleeding, how the blood creates these little conglomerates, these little jello forms in the abdomen if you do an open belly case. Like a C-section is just a good example, but you can see in a lot of different places. And you can see how that blood forms into these clots. And when you try to remove them or suction them or get them out, that they sort of stick together. And that's what we're talking about here today. And some of that is, like I said, it's not hard to understand, but it's easier once you've seen it. So pay attention in those rotations specifically, and you'll get a better idea of what we're talking about here. Now, why does the blood form clots at all? Why do we want this? Well, the idea is you don't want to bleed to death, right, from a tiny little cut. So when you get a little cut, that blood clot helps to slow down the bleeding and allow time for the blood vessel to repair. We're going to go through this in a little bit of detail. It's kind of circular, and a lot of things happen at the same time, so it's hard to talk about because things that influence each other are happening simultaneously. So to talk about them separately gets weird, but we can't give the information in any other fashion. So that's how we're going to do this. If you think you need more, there are tons of places online to find more detail about the clotting cascade. There is more depth to this by far than what I'm going to cover today. I can't stress that enough. This is a 15,000 foot overview of the clotting cascade. Like I said, I know I've repeated myself already, but I want to make it super clear. This is not a detailed discussion. This is the overview. And my philosophy is always you do that overview and then you hang the details in later. Once you really get it, it makes it a little bit easier to understand rather than just cramming through the details. So let's start with our overview. We basically have two main players. We have the platelets and the clotting factors. Clotting factors tend to be proteins, but calcium is also in there. Clotting factors work with the platelets, and the platelets work with the clotting factors. They sort of antagonize each other to create blood clots. Primary hemostasis, and again, this happens pretty much simultaneously with secondary hemostasis, is when a blood vessel is damaged, right? So you get a cut or something in the blood vessel. Then the subendothelium space is exposed to blood. So the blood leaks out where it's not supposed to be. Blood is not supposed to be in the subendothelium. It's supposed to be within the blood vessels. So as it moves into the subendothelial spaces, this triggers a bunch of things to happen. And again, I'm not going into great detail here. This is a super oversimplification. This whole system is designed to stop that bleeding from happening into those subendothelial spaces. Platelets will bind directly to the collagen in the subendothelial space. So when the platelets come in contact with the collagen in that space outside of the blood vessels, they will attach to it. Von Willebrand's factor will increase the binding between the platelets and the collagen. When platelets become activated, they release von Willebrand's factor and platelet activating factor, PAF, as well as thrombin and a number of other proteins into the bloodstream which interact and attract more platelets and boost the clotting cascade. Lastly, these platelets are cross-linked by a protein called fibrinogen. So there's a whole bunch of stuff there, and this will be a little bit more clear as we go, so hang with me. In secondary hemostasis, the clotting cascade is a series of enzyme reactions where one protein acts on another protein, thereby activating it and turning it into another enzyme, and then it'll act on another protein, and so on and so on. Again, super oversimplification. The final endpoint is where we turn fibrinogen into fibrin. The clotting cascade leads to the creation of fibrin, which is a tough, stringy protein that forms a web or a mesh that helps to hold the platelets together. It's like this sticky, thin, filmy stuff that holds the platelets together. You can picture it that way. And that's kind of the whole point of the clotting cascade, is we go through all of these different enzymes and all these different proteins to create this fibrin meshwork over top of the platelets and get those platelets to bind together. Now, towards the end of the clotting cascade, let me back up just a second. The clotting cascade can be described as having two different pathways depending on which proteins are activated first. Again, lots more detail here than I'm not going to go into, but there are two different pathways to activate the clotting factors. There's the intrinsic and there's the extrinsic pathways. Towards the end of the clotting cascade, you wind up at the common pathway, which means both of these kind of run into each other at the end. And at this point, factor 10 activates prothrombin, which is factor 2, which creates thrombin. So that's designated factor 2A. So factor 10 turns prothrombin into thrombin. Thrombin then turns fibrinogen, which is factor 1, into fibrin, which is factor 1A. The A designates active. So at the end of the clotting cascade, you get prothrombin into thrombin, and then thrombin interacts with fibrinogen to create fibrin. That's the end point. And to me, that's the part you really need to know. You really need to be familiar with this. The thrombin acts on fibrinogen to create fibrin. Now, for me and what I do, I'm in surgery, right? So a lot of this stuff I relate to through the surgical patient. And you'll see as we move forward a little bit of how that works. But in particular, here, we use products that are fibrin glues, essentially, a fibrin seal that you can spray over tissue that will help with bleeding issues, right? Because that's the sticky substance that helps platelets stick together. So we literally just spray it right onto the tissue. It also helps with seromas and to keep the tissue sort of stuck together, places that you're not going to put a suture in. There are also other products we use for hemostasis that contain thrombin in them. Again, it just helps to create that clotting cascade or to push forward that clotting cascade to reduce the bleeding. All right, let's talk a little bit about anticoagulants before we move on. But I want you to understand, again, and I hate to be repeating myself over and over here, but the clotting cascade is super complicated, right? Well, maybe not super complicated. It can get there, but what you've learned, it's pretty complicated. And you understand these cycles, like the Krebs cycle, and how different materials move through it and create different results. To me, the important part for us to get out of this is we wind up with a fibrin covering platelets to create a clot. That's really, really the key. And it's just this cascade of enzymatic reactions to get there. If you can remember the end bit, that common pathway at the end, I think that's really valuable. But all of the steps before that, for the most of us and for your exams, I just don't see it being worthwhile. So some things here to know. Now let's talk a little bit about anticoagulation. Because as we move forward, this is going to matter. And I don't see a place where it fits in better, so we're gonna go ahead and put it in here. So we'll start with heparin. Heparin is a thrombin inhibitor. Well, what did we say that thrombin does? Thrombin acts on fibrinogen to create fibrin. So if we can inhibit thrombin, then we get a decrease in the production of fibrin. I'm going to talk about this in relation to warfarin or Coumadin, because that's the way it's going to make the most sense and the way I think it'll be used in your exams and the way you'll use it clinically. Heparin has a faster onset and a shorter half-life than warfarin. You can use it IV or IM. So we're going to use heparin if we wanted to get a blood thinner in quickly. We're going to use warfarin if we have a little bit more time and we want to do a more long-term management. And there are lots of reasons why you would want to put someone on blood thinners, right? AFib is a great example. You get atrial fibrillation, you get some blood that may settle in the atrium. So you don't want that to happen. You don't want to form blood clots there. So you put the patient on anticoagulant long-term, and it keeps that from happening or reduces the risk of that happening, right? I think about it again more in a DVT risk for patients post-operatively, that sort of thing. So if we want something quick acting, we will use heparin. You can also use it in pregnancy, and you monitor it with a PTT or a PTT, and we'll get to that in just a second. Normal PTT range is 30 to 40, and a therapeutic range for heparin is 60 to 80 seconds. Again, just give me just a second. We'll get into what that is. All of this is sort of circular, so it may not make sense in a straight line. Warfarin, or Coumadin, is a vitamin K agonist or antagonist. Vitamin K is necessary for the production of clotting factors. Let me say that again. It's a vitamin K antagonist, and vitamin K is necessary for the production of clotting factors. So that's a lot different than heparin, right? Heparin actually blocked thrombin from functioning. Warfarin stops the production of clotting factors. So this is a slower onset of therapy with warfarin. It takes about 3 days to get to the anticoagulation area you want to be in with warfarin. It takes a little bit of time. It's given orally, which is convenient, and I'll get to why in just a second. It's monitored with a PT-INR, and a normal PT-INR ratio is 0.75 to 1.25, and a therapeutic range for warfarin is 2 to 3. Here's why the oral part matters. If we are going to treat someone for AFib long-term, we're going to give them the oral medication, warfarin. 1, they can take it at home, and 2, it builds up a little bit longer in the system, and it takes a little bit longer to get out of the system. So if you miss a dose, it's not that it's okay, but it's a little better than if you miss a dose of heparin. Heparin is IV or IM, so something we may not want to use in a home in a home setting, right? It'd be more in a hospital setting. But it does take a couple of days. So if we have a patient who would normally go home on Coumadin for a knee replacement, you're going to have to give them heparin right after surgery to cover that 3-day window if you don't start the warfarin till the day of surgery. I hope that makes sense. So heparin is more fast acting and works directly on the clotting cascade at the thrombin level. It inhibits thrombin. Coumadin is a vitamin K antagonist, and it works to prevent the production of clotting factors. And one other thing that matters there is if you have a patient who's on Coumadin, usually what they do is they warn these patients to try not to overeat in green leafy vegetables, that sort of thing, which are high in vitamin K, because if you have a lot of extra vitamin K in the system, it will decrease the effectiveness of warfarin. All right, next on our list, we have NSAIDs and aspirin. These work through a little bit different mechanism for anticoagulation. This blocks the thromboxane A2, which would normally stimulate platelet activation and platelet binding. So these are kind of like platelet inhibitors. So we're working on different pathways here, right? All 3 of the medications we talked about work through different pathways. Heparin is on the clotting cascade. Warfarin's a little further up the chain. Blocks the clotting factors from being produced. NSAIDs and aspirin block platelets from activating and from platelets binding. Again, the active platelet will put out different chemicals in the clotting cascade. It will put out von Willebrand's factor. It will activate other platelets, and it will bind to other platelets. Our last anticoagulant I'm going to talk about right now. There are other things out there, but again, we're only going to cover so many of them. Tissue plasminogen activator, TPA, which you've all heard of and use, that we use for stroke treatment. If we believe there's a clot, these are clot busting drugs. Well, what do these do? Why are they clot busting drugs? These activate plasminogen. So another funky protein that you need to know the name of. Plasminogen is the precursor to plasmin. Plasmin will cut through fibrin. And that's the key here. Plasmin will cut fibrin and dissolve blood clots. That's how it works. So this is a very powerful drug, the tissue plasminogen activator, and it's just right in the name, right? If you remember TPA, you kind of get it. But if you remember tissue plasminogen activator, Plasminogen turns into plasmin, and plasmin cuts through fibrin. And again, I think early on, I said, you need to know that fibrin is the end point. You don't need to know the whole clotting cascade. You don't need to know the nomenclature. You don't need to know which Roman numerals weren't used because they never discovered the material they thought was there. There's so much background information here, and it's actually kind of interesting. But you don't need it all as far as a PANCE level exam goes. So TPA has the effect of dissolving fibrin, dissolving blood clots. All right, we're going to talk about a few labs here before we go on. Actually, that'll wrap us up for today. Partial thromboplastin time, or PTT, or activated partial thromboplastin time, APTT. These are used to assess the intrinsic and common coagulation pathways I talked about earlier. Through lab work, you can determine there are two different pathways for the coagulation cascade, the intrinsic and extrinsic. I'm not going into those in detail here. These can be used to assess the intrinsic and common coagulation pathways. The normal range for PTT is 30 to 40 seconds. A delayed PTT is caused by heparin, which the therapeutic range is 60 to 80. So we're 1 to 1.5 to 2 times our normal range there. So heparin will interfere with the intrinsic pathway. Hemophilia is another reason we can get delayed PTT because we don't have specific clotting factors. We'll get into hemophilia next week. But that's when we're missing specific clotting factors. And then sepsis is another one because you can get consumption of clotting factors during sepsis. So it's as if you are missing those clotting factors. So again, the key here for you and for me, quite honestly, is that PTT is how we assess heparin therapeutic range. We use a PTT for that. We can also use it to test for hemophilia. The normal range is 30 to 40, and the therapeutic range for heparin is 60 to 80. Prothrombin time, PT, or international normalized ratio, which is INR. What they did here is prothrombin time is to use to measure the extrinsic pathway. But the materials the labs use to do this have certain characteristics. So the INR is a way to normalize those characteristics and give you a range that makes sense amongst other labs. So it's not really complicated. A PT and an INR are basically the same thing. The PT is the pure data, and the INR is sort of a calculation to normalize it across to other labs based on the reagents and materials used within that lab. So a normal INR is 0.75 to 1.25 or 0.80 to 1.2, depending on what you read. And a cause of delayed PT-INR, warfarin. So a therapeutic level would be 2 to 3. So remember, I just said our normal range is 0.75 to 1.25, and a therapeutic level for warfarin is 2 to 3. And then liver damage, where you're not producing these clotting factors, can also increase INR. Bleeding time. This is used to assess platelet function. Here, the patient's actually cut under standard conditions and is observed until bleeding stops. And then our last lab for today is going to be the D-dimer, which is a byproduct of blood clots being broken down in the body. And we can test for that. And an elevated level may indicate a large amount of clot within the vascular system. So this can be used to look at a DVT or a PE, that sort of thing, and get you a little bit more information. So one thing to understand, and it's going to come up as we move forward, is your body's making these clotting factors, your body's making these platelets, and they're not all activated, right? That's part of the point here. So you're wondering, why do we need to have all these different things activating these other things and making this so complicated? And one of the reasons is because it's just the way it works. So so you have to learn it. You don't get to decide how the system works. But the system works because you have these proteins floating around in the blood that are all throughout the bloodstream. So when something happens, they're already present. They just need to be turned on. They don't need to be produced and shipped. So let's say you got a cut in your finger. Your body doesn't say, okay, let's produce some clotting factors in the liver and we'll send those over to your finger. It doesn't work that way. Your blood is filled with these clotting factors and these platelets, but you don't want them turned on all the time or else you'd get these clots everywhere. So they're all in these off positions until they're stimulated. So all of this is a measure of control over the system. And you have to understand that there's a significant balance between clotting and breaking down clot. That's where those D-dimers come in. You say, how come we're looking for the product of clot being broken down if we're looking for a clot? It's because clots are always being broken down. All right, there's always that next step of breaking those down. Those enzymes that break down clots are also floating around in the bloodstream, looking for clots to break down. They don't know anything, but when they find a clot, they start to break it down. And that's the way the system stays in balance. As soon as a clot is formed, there's another system that's trying to break that clot down almost immediately. So it's a constant balancing act. And when we lose track of that, and we'll talk about this further down the road, is when we get into things like disseminated intravascular coagulation, DIC. Well, now we have clots forming everywhere within the bloodstream. And we're simultaneously forming these clots, but we were also using up all of our clotting factor, so we're also bleeding. So it's a very difficult balancing act, and that's one of the reasons why the system works the way that it does. All right. So before we finish up with our priming questions for today, we're going to talk about our study tip, which I mentioned briefly earlier, which is the difference between memorization and understanding. And why I do this review as like I said, a 15,000-foot overview is because I think it gives you a basis for understanding. And I think you should go back. You'd be surprised how long it took me to put this particular episode together. It took me hours and hours. I'm looking at the number of words I have written down, and it's half of what I normally write. But it took me a long time. And part of that is it's a very complicated system that I'm trying to turn into the smallest amount of information that's important for you. And that's one of the things that I can do for you that's very valuable, is I can take these broad, detailed, difficult topics and make them a little easier, a little more clear. So to me, starting at that 15,000-foot view, understanding the big picture and how it works, and then going through the details and adding them on, almost like getting a Christmas tree set up and then adding on the ornaments, rather than trying to do all the ornaments at once and then going to get the Christmas tree and figure out the Christmas tree later. Like, I think that's the hard way to do this. I got to come up with a better analogy, but I think that's the hard way to do this. I think the easier way is to get the framework up and then add in your details and then connect your details to each other. So to me, the idea here, the understanding part of this is, what do I need to know? How does the system work? I need to know about clotting factors. I need to know about platelets. Well, what do I need to know about each of those? I need to know that platelets stick together. I need to know that von Willebrand's factor makes the platelets stick to the collagen. I need to know that fibrin makes the platelets stick together and covers the whole thing into a clot. I need to know that that's simultaneously trying to be broken down. Okay, I got that. I have basically an entire overview in less than a paragraph, and I can hold that in my head. I understand it. Now, what can I add to that? Well, I can add to that fibrin comes from fibrinogen, and that thrombin cuts fibrinogen and creates fibrin. All right, now I've got one more detail, a little more color, a little bit more in there that I can understand. I can learn that heparin inhibits thrombin. So it inhibits fibrinogen turning into fibrin. So it makes sense to me that if I give a patient heparin, I'm going to reduce their ability to clot. Okay, that's great. That makes total sense. So to me, that's a great way to learn, is to start with that really wide view and then just keep adding in the details. Now, you can just memorize for sure, and there are places to just memorize. I don't think that's a bad thing, and don't think that's what I'm saying here. I think there are lots of good places to just memorize things. You're going to have to just memorize that the therapeutic range for warfarin is 2 to 3. There's not much to attach that to. You're going to have to memorize that heparin's therapeutic range is 60 to 80 seconds. There's not much to attach that to. If you understand what heparin is and does, you can kind of tack it on the end there, and it'll stick longer. But that's not really an understanding thing. I mean, you can go a lot deeper and make it an understanding thing, but I don't think it's worth the time. And then once you understand warfarin and heparin, then you can kind of, and this is how I have this set up, you can move into PTT and PT and what we're testing. And again, there's a lot more details and a lot deeper you could go. But for me, I think that's probably good enough. Or at least this is what I would be studying and did study when I took my PANCE and my PANRE. I chose not to go deeper than this, and it was enough for me. You certainly, like I said, there are tons of places you can go to find more online and in your textbooks on all of these topics. And it's entirely possible you will need that for your practice. It's also entirely possible that you won't need it for your practice either. All right, let's go ahead and wrap this up with our priming questions. How does warfarin work? Well, it's a vitamin. Let me give you a second to think about it. It's a vitamin K agonist. So vitamin K is necessary for the production of clotting factors. So we increase the time it takes to make clotting factors and make it more difficult to make them by getting rid of vitamin K. What is one thing von Willebrand's factor does to increase clotting? Actually, there's a couple of things, but we only talked about one today. It helps to increase the binding between the subendothelial collagen and the platelets. Factor 1A is the tough, stringy endpoint of the clotting cascade. What is its other name? For me, this is a big one. If you can hold on to this, I think you really will start to get something out of this knowledge. Fibrin. All right, so like I said, this was supposed to be the brief introduction. And then we were going to talk about hemophilia A, and we were going to talk about von Willebrand's disease and all these things. And all of a sudden I realized that was not how this was going to go, that this is a bigger topic and it needs sort of a groundwork, a floor work set up for it. So I hope you got a lot out of this. I would recommend going through this particular podcast again, getting some pictures and taking some time and actually going through this until it sinks into your brain a little bit. I think it will be much, much easier moving down the road if you handle it that way. Anyway, I want to thank you all for coming out today. I really appreciate you being here with me. This is so much fun for me, and it's so much more fun knowing that you're out there, that you're getting something from it. I've been getting a ton of emails of people saying how they've been passing their PANCE, a few who haven't, and we'll work with them, and how the show has just been really helpful in getting them to understand not just topics, but study tips, all of that stuff. And if you're looking for more in the way of study tips, head over to the website, www.physicianassistantexamreview.com, and sign up for the email list, and I will be sure to get you a ton of stuff as that goes. So anyway, take care, and I will see you soon.